It looks like there was a duplicate Teams link that was sent to on the calendar invite. So some people are in that Teams channel, so we're just letting them transition over to the Zoom meeting, and then we can go ahead and get started. All right, so we can go ahead and get started today. And I think you all can see my screen. Can someone nod their heads if you can see? Okay, perfect. So good afternoon, everyone, and welcome to our Marcus Alert Statewide Stakeholder meeting. This is the third convening we've had since implementation back in on December 1st of 2021. And we have this meeting every 6 months. It started with just the original stakeholder planning group that developed the state plan, and the group has grown to include others who are interested in learning about what's going on with Marcus Alert and just keeping people informed about the process. And we just made a commitment to continue meeting with this group every 6 months to continue providing updates on the status of Marcus Alert. So today's agenda, it's starting with me just giving an overview on some updates, but we also have a pretty packed agenda. I'm excited for our data analyst and major to give an update on Q1 and Q2 data that's been collected so far for Marcus Alert. We'll have a presentation also about 988 in Virginia. This is a tweak to the original agenda that went out. Unfortunately, Bill Howard will not be able to join us today to give an update on the crisis continuum or that tie into 988, but that's something that we can do at our next presentation to talk about how 988 allows access into the comprehensive crisis continuum here in the state. And then we'll hear from the town of Culpeper and the co-response teams, and that's going to be a co-presentation between Culpeper Police Department and Rappahannock Rapidan CSV. So we did block off some time at the end of the meeting for a Q&A session, but we also want to make sure that questions are answered throughout the session as well. So if there is a question that you have, just general housekeeping, or asking if you can use the function to raise your hand in the meeting. You can also put any questions in the chat, and we'll monitor that to answer any questions that arise during the meeting as well. If it's a larger topic that might be not centered around what's being discussed at that time, then we can table that question until that end at the Q&A session at the end of the agenda. I want to reintroduce the team, the Marcus Alert team, just so statewide you all are familiar with what resources can exist out there. So at the state level, we have myself, I'm at the Department of Behavioral Health and Developmental Services. And my counterparts, Dallas and Ashley Hart, are at the Department of Criminal Justice Services at DCJS. And they've joined us on this call today as well. And then we have regional Marcus Alert coordinators that are locally employed. So in Region 1, there's Erica Vesley, and I believe all of the regional coordinators are also on the call at this time as well. In Region 2, we have Dana Johnson, who is kind of overseeing that role. I believe they're still recruiting for a direct Marcus Alert coordinator as well. In Region 3, we have Chris Parks, and he's based out of Highland CSB. In Region 4, they're recruiting for that position, but Jenny Kelly and Amy Arab have been kind of acting in that role or helping facilitate some of those responsibilities. And then in Region 5, Stacy O'Toole is currently kind of filling in that role where they just lost their regional Marcus Alert coordinator last month. And so this is the staff that we have that's able to assist with Marcus Alert. Oh, I see Wendy's comment, but Dana is not interim. I'm sorry. Dana is the real deal, is what Wendy posted. I didn't know if you all were hiring two separate positions, but Dana Johnson is permanent, so I'll have to update these slides before we send them out with her email address on it as well for contact. So thank you, Wendy, for correcting me. All right, and so we can go ahead and lead into the Marcus Alert data reporting presentation. And I will handle the slides. Anne, are you ready to go ahead?
Yes, I am. Thank you.
All right.
Good afternoon, everyone. As Alexandria had mentioned, I'm the Community Crisis Data Analyst here at DBHDS. So I'm the data analyst for the crisis services, and that's where Marcus Alert falls in as well. So I'm just going to provide an update in terms of data collection and what we've had thus far for Marcus Alert. Just as a recap from our last meeting, we kind of left it off. We had just started data collection July 1 of 2022 with the initial implemented areas. Oh, Alexandria, can you advance to the next slide? Thanks. And so we had developed a template, a data collection template for the PSAP to capture 5 data elements. The first data element was the PSAP CAD ID number, which essentially was going to serve as a unique identifier for all the calls that are transferred to 988. And then the date of the call, the time of the call, also capturing the Marcus Alert level, and also capturing the last element is the call response, previously noted as the 911 disposition. These dispositions or responses included like either if it was no transfer, if fire and EMS was dispatched, law enforcement was dispatched, if a specially trained law enforcement officer was dispatched, co-response teams, and also transferred to 988. We changed the terminology a little bit from call response, from 911 disposition to call response, because we had received feedback from the PSAPs regarding the wording of 911 disposition, so we updated that language. The intention of that data element was to capture the action that was taken at the level of the phone call and not necessarily the final disposition of the entire call. So we updated the template, and that's just a slight change from the initial implementing groups. And then we've also sent this template out to the second group that's planning on implementing, and their data collection will start July 1 of 2023. So that's kind of where we are in terms of the template. We have collected data regarding the calls that are captured. Sorry, can you advance to the next one? I keep advancing mine, but yours is not going. So let me, thanks. So looking at the data that we've collected so far from July 1 to December 31st of 2022. So we've collected Q1 and Q2 information. And as you can see from the PSAP 911 localities, we've captured quite a bit of information thus far. And you can see that the total number of 911 calls that are listed, and then of those, how many were coded as Marcus Alert related calls. This is the first time for collecting this data in this manner, particularly with all the different CAD systems existing. So I think it's quite a feat and kind of an accomplishment to see that so many PSAPs that were involved in this initial implementation were able to code Marcus Alert, train their staff, and also, change their CAD systems. So looking at this data, you can see that the Marcus Alert related calls range from about 1% to about 2.5%. or from less than 1% to about 2.5% to almost 3% of calls are coded as Marcus Alert. And that indicates about an average about 1% of the 911 related calls as being coded as Marcus Alert. And when I say coded as Marcus Alert, that means that they were a level 1 through 4 was identified with those Marcus Alert calls. So we had received data from most of the regions, keeping in mind that some of the regions had multiple PSAP locations, so collecting data from up to 5 911 centers at one location or one region. So that's kind of like an overall perspective of the number of calls and then how many are related to Marcus Alert. Jumping to the next slide. So then, as I mentioned, we also capture the call disposition or the call response. And this is, our baseline initial data. And these are of those Marcus Alert levels, and this is including all Marcus Alert levels from levels 1 through 4. What was the call response? And we can see in these numbers that the other we actually group together are the responses either with law enforcement or without law enforcement. There was a no transfer, or if it was a fire or EMS that was dispatched. We kind of broke out and looked at law enforcement and what their response is for that, and also specially trained law enforcement that was dispatched. Looking at this graph, the green bars are Q1 and the blue bars are Q2. And you can see a majority are ranked at the top or others. So that's either co-response, no transfer, or fire EMS. Coming in second, the most frequent call response is law enforcement only. But you can see compared to Q1 and Q2, there was a great decrease in law enforcement being called out or dispatched for the Marcus Alert level calls. And you can see on the third ranking, there is a huge increase regarding specially trained law enforcement being dispatched between Q1 and Q2. Looking at the different quarters, that's about 40% decrease in law enforcement getting dispatched, and almost a 71% increase in the numbers of calls that were dispatched by specially trained law enforcement. And as you can see, there's also that we also kicked off calls transfers to 988 with 117 for all Marcus related calls in Q1, and then 78 in Q2. And then we did a further deep dive in terms of the Marcus Alert, just looking specifically at Marcus Alert level 1s and levels 2s. And you can see that law enforcement is the #1 call response made. However, again, we see a decrease in those responses that are coded for level 1s and 2s. And again, also you can see that there's an increase with the specially trained law enforcement being dispatched, and also calls to 988. And you can see if we compare the transfers to 988 from the previous slide to this slide, most Marcus Alert level 1s and 2s are getting transferred. The transfers are level 1s and 2s for those calls, which is what we would expect, that most Marcus Alert calls that are coded as 1 and 2s are getting do result in that, and that we wouldn't expect any transfers to 988 to be either the level 3s or the 4s. Any questions with that? I'm not looking at the chat. I can't see the chat. Is there?
This is Dr. Young. I have a quick question in terms of the level 1 and 2 and the transfer from 2988. Are those specifically areas that already had their police officers trained, and that's why the increase?
I'm not sure. That is something that is certainly an area that we would like to look into and dig a little bit deeper in terms of if they were already trained or additional training was made as a result of Marcus Alert. But like I had mentioned, it's just like, this is the initial baseline data. So there, of course, with data received, there's also a ton of questions that come when you get data. And so those are some of the questions that we would love, that we are planning on kind of taking a deeper dive of, in terms of how each localities had coded the Marcus alert, and then how that impacts the response as well. I know that fully didn't answer your question, but yeah, this is just the initial kind of results of the data, and certainly a lot more digging into.
Hi, this is Brad with Chesterfield PD. Just so make sure I'm reading this right. In the first 2 quarters, you had about 900 and some calls that law enforcement only went on for level 1s and 2s. Is that what you're saying?
For level 1s and 2s, yes, law enforcement was still being dispatched for roughly about 900 calls.
Okay, thanks.
When we are talking about specially trained law enforcement officers, assuming CIT training, yes, that's correct. Some type of specialized training, like the crisis intervention training. Yeah.
And this is John Lindstrom at RBHA. Is the data that you're reporting on PSAP calls only from PSAPs in the 5 initial implementation sites?
That is correct. Yeah.
So we can make some assumption that some of the change may have to do with implementation of other elements of Marcus Alert. Response protocols and the like.
Yes. Yep. As related to Marcus Alert. And thanks for the clarification, Amy. Calls are transferred from 911 dispatch centers, not law enforcement officers.
All right, I didn't see any other questions going to the chat. Did anyone else have any questions for Anne over data?
And we can also forward a copy out of these slides after our meeting as well, if anybody was interested. I know I've had a few asks for them.
Yes, we'll send the slides, and also this meeting's being recorded, and the recording will go on our YouTube channel as well. But we'll definitely send those. It looks like Patrick had a question. Are we able to explain the drop from Q1 to Q2 in transferred calls? I imagine. Go
Yeah,
ahead.
that is one of the questions that we are looking into. I know Alexandria and I in the Marcus Alert team do plan to do like on-site visits to kind of get some additional information. We've gone out to a couple sites, but we certainly, sometimes the numbers we need to provide or kind of get a further narrative as to like the explanations behind the numbers. So that's part of our process as well. So yes, that is certainly a question of the reason why there is a drop in some of those transfer to 988 calls. Thanks all. And as always, if there's any questions that come up or anything, feel free to reach us. Thanks.
Thank you, Anne. And I know Patrick did actually hit on something that I wanted to provide an update on in the top of the agenda in the welcome section. So it allows me to bring it up now that we're a little bit ahead of time. And so an update we have is that recently, or actually this was in last year, at the end of last year of 2022, we were able to request, with the help of actually at the lead of our regional coordinators, we're able to work within their regions to get regional implementation list when it comes to Marcus Alert and who will be implementing in kind of what order within the regions. What that information allows us to do is to help localities better plan. So we're able to provide specific dates that we need information by to each of those communities. So we are, one region is still kind of finalizing their plan, so that's why we have not yet put anything out. But once we receive this information from all 5 of the regions, we'll be able to say specifically these PSAPs, these law enforcement agencies, these institutions of higher education. This is when you are required to submit this information to our agencies, and providing those specific dates I know is something that localities have been looking for, and it will be helpful. And that kind of ties into Patrick's question on the PSAP template about when they're required to have that for the different 911 centers, or when they need to start transferring those calls, so we can provide more specific dates to each locality once we're able to get those complete lists. And I'm expecting that to be done soon, or we should have those lists finalized soon. It does look like, Anne, maybe there's another question about do we have data on calls directly to 988 to see how the PSA campaigns are helping? So part of this, so this upcoming summer is when there will be a national campaign about 988. And Virginia also will be launching a campaign about 988. 988 did launch, and our next presentation is about 988, so I don't want to steal their thunder. It'll be from our 2 call center providers in the state. But there was a soft launch in July, or July 16th of 2022. And but there will be more attention brought to 988 as services are more established from what they were last summer. And so I guess to answer this question, we currently are not capturing like those KPIs or key performance indicators around campaigns, but that is something that our marketing consultant, our contractor, will be capturing around campaigns that are launching statewide, and looking at numbers related to 988 as they come in. And that's something it's captured, or it will be captured in our crisis data platform, as well as Sidel, is the vendor that's going to be doing those marketing efforts. They will be looking at measuring the success of those campaigns. So hopefully that answers your question, Teresa. And with that, I'll go ahead and lead into our next presentation, which is going to start from PRS Crisis Link. So we have Laura Clark with us, and Laura Clark is the Senior Director at PRS Crisis Link, which is one of the crisis call centers that supports 988 in the state of Virginia. Laura, are you ready?
I'm ready. Thank you, Alexandria.
Great.
And thank you, everybody. I see so many familiar faces, many who I've met with today, so good to see you all again. I'm going to talk a little bit about 988 as a whole, and then specifically about PRS Crisis Link, and then Celeste will talk about her awesome work in Region 3 with Frontier. So kind of starting off, advance the slide. Crisis Link is accredited by the American Association of Suicidology and the International Council for Helplines. And kind of the nuance here is, to be a 988 center, you must have one or both of these accreditations to be part of the network. And so Crisis Link and Frontier are accredited to be part of this larger network. And there's a lot of requirements that go along with that. So 988 doesn't accredit a center. 988 agrees on who accredits the center, and then we submit our documentation for that. So we are a 24/7, we never close operation. We have 24-hour clinical staffing, and we are networked suicide and crisis lifeline center. So we are one of over 200 centers across the nation answering 988. If you could move to the next slide. So 988 is administered by SAMHSA, so it's a federal function, and you'll see here that the vision that 988 has for the entire network is very similar to the vision that we have here in Virginia. That when you dial 988, that there's someone to talk to, someone who's going to respond, and then a safe place to go. And this is kind of what everyone's been hearing for the past several years of how we're building out this crisis continuum. And that is the expectation for 988 moving forward across the nation, so that there isn't so much variability between all of the centers in all the states that are part of this larger network. So someone to call could mean a phone call, it could be a chat, or it could be a text. And each one of those are growing in awareness and operational staffing capacity, and have we been using this past year to do that. So as part of this 988 vision, as Alexandria has said, last July is when the FCC compliance date came up. And that meant that every phone provider had to activate 988 as something on their phone. And once that compliance hit is when all the capacity building was going to happen. So we have a full year to build up our staffing, to prepare for national campaign and grow in policy and procedure to adapt to this 988 vision. So that's what PRS and Frontier has been doing since last July, is really building up how we're going to integrate 988 through our regional partners and CSPs and state partners, how we're going to integrate 988 into this larger continuum, because the visions are very similar. Next slide, please. So 988 is a complicated thing. None of this has been simple, and it's not easily understood by the public. And so we just kind of want to give you a sense of how it's currently operating and what some of those limitations are. So when you dial 988 from your phone, the network is going to look for the area code that is associated with your phone, which 703, 757, 804, 571, whatever that number is. And it's going to route based on that 3-digit code. And that's the call center assigned to that 3-digit code. That call center is supposed to be the local resource. And if you have a landline, that's really great. If you have a mobile phone, it may not align. And so this is something that, like PRS, Frontier, the state, no one has any real control over, because it's an FCC directed, like basically association with your number and your service that you provide. And 988 hasn't been given a designation at the same level as a 911 center. And so for right now, and has been for the past 20 something years, everything is routed by area code. So you can imagine that does create some challenges for areas in which people have cell phones that don't match 988. And that's what our regional partners have been working very hard on, is to figure out how to best serve people in Virginia and making sure they get access to the regional crisis call centers with 988 or using other phone lines. But that's a limitation that we cannot change ourselves. That requires the federal government to make that designation and that change. Next slide, please. So Crisis Link has been a center for a long time. We started when the phone number what used to be 1-800-273-TALK. And that's another nuance to this work, is that 988 isn't actually new. The infrastructure has been around that other phone number, 1-800-273-TALK. 988 came with federal appropriations and a renewed interest in getting people better access to 988 and better funding. The Lifeline used to be funded, I think it was a whopping like $5.2 million for the entire nation. And now it's over 400 million. So that new appreciation and pressure to really address mental health concerns came with this additional funding. And that's kind of how we got to where we are today, with new standards, new phone number, and a new brand. As a center, we do state work, which I'll show in a minute, our coverage area. We also do national backup. So we are a center that if there is overflow to other centers, will answer those calls. And so that averages about 5,000 to 8,500 988 calls per month. We do text as part of a national effort, and we'll hopefully be extending that to the state in the near future. But in addition to all of that, which sounds like a lot, we have a lot of other crisis access points coming in as well. We have regional lines, we have text lines, different things that have been stood up in different communities. So we have a lot of different places coming in on top of, since December 2021, obviously we've been doing PSAP diversion in 4 out of 5 of the regions. Next slide, please. So the PRS Crisis Link coverage area for 1, 2, 4, and 5 looks a little like this. So anything with color is kind of where we're operating. This part of the coverage has been something we've been doing for a long time as part of Lifeline, but not necessarily in the same role that we are now, which is the Regional Crisis Call Center. So In each one of these different color areas, we are partnered with amazing people who are helping us figure out how to navigate the behavioral health system and feed into it, versus before, the Lifeline kind of operated on its own and didn't have a formalized connection into the behavioral health system. So now that's formalized with additional resources, and people are getting better care because it's not as such like we serve somebody, give them a phone number, move on. It's we serve somebody and help them connect to their behavioral health access points within their own communities and make sure that's a warm handoff or a mobile crisis or whatever service that they need. So it's much more of an embedded process. Next slide, please. One of the biggest questions is who staffs it, and are they all clinicians? And the answer is no, because we would take every clinician from every service to run this operation, and that wouldn't benefit anybody. So we've had to adapt, and we have our frontline, our paraprofessionals that receive a minimum of 120 hours of training. Most often, these are people who are working on their masters, people who have a really special interest in becoming behavioral health professionals, or they're people with lived experience. And so we have a pretty diverse population, and we operate within a virtual call center because we employ a little over 200 people to do our regional work. We have clinicians on the back end reviewing. So that's the clinical staffing for mobile crisis, for active rescue, for care navigation. Clinicians are reviewing those cases for accuracy and appropriateness and ensuring that those levels are correct and that they're getting the right level of care. And then behind that, we have operational supervisors who manage more the technology side of the house, and some emergency communication people or dispatchers. We try not to use that designation because that is something that's a little different, but people who understand emergency communications to navigate mobile crisis, and as well as our connections to PSAPs. So it's a large group of very diverse people, all with a function, trying to make sure that we're the most effective and efficient operation, that people are being served with a really high level of quality. Next slide. The other piece I just kind of wanted to give some insight to is, so when somebody calls, what are the outcomes that are most typically associated with their calls or texts or chats? And about 90% of people who call are resolved at the call center. We provide emotional de-escalation, we provide coping resources, and if they have another need, we warm transfer to that service. So it could be a CSB, it could be for housing, it could be for food. Most often it's for outpatient services for behavioral health. But the point of 988 is not that we're just addressing mental health. People call with whatever is a crisis, and a crisis could mean they don't have enough diapers for their baby, that they don't have lights on in their apartment, that they have a medical need that's not being addressed. So when we say 90% of calls are de-escalated, we're not talking 90% of behavioral health calls. We're talking about 90% of the total volume that comes in, which could be anything and everything. We do domestic violence, we have child abuse reporting, adult abuse reporting. There's so many things that come in. And so sometimes that gets lost, I think, in the larger picture that, if you answer 5,800 988 calls, they're all mental health, and that's just not true. It's much, much smaller than that. We have offered about 20% of our Virginia callers another layer of care navigation. Many people don't accept. We're still working on getting people to agree to it, but they call, they want to be done with that call, and that's it. But some people do agree, and that's for more complex referrals, things that can't be more immediately resolved in the moment. It's more than just a warm line transfer somewhere. There's usually competing needs. And so we've been operating with that, and it's been a huge benefit to people who do have more complex needs like language, transportation, housing, and behavioral health altogether. Sometimes calls result in mobile dispatch, which means whatever kind of methodology we have, we provide a connection to a mobile resource. And that's a smaller number, and it's harder to get a hold on that number currently, so I don't have a percentage. It's offered quite frequently, but it's something that not everybody wants or agrees to. And that's that level 1, level 2, more appropriately level 2 response that we have available. And then less than 2% of all the calls coming in are referred to public safety for an urgent response. And that's the goal, is that we're able to serve at many other levels outside of our PSAP partners whenever possible. I will say, as a caveat to this, there is confusion still about 988 and 911. And so we might see this number trend up a little bit because people do have confusion about the two numbers, and they will call us instead of 911. And so we've seen a trend of transfers to PSAPs because of a medical emergency versus everything coming in is all strictly behavioral health. So we're keeping an eye on that and talking with all of our partners about, what we're seeing in that trend, to come up with solutions to make sure that people are, as we move forward in the campaign process, that are better educated about the differences between the two. But generally, that's kind of one of the 4 responses that you'll get if you dial 988 or one of the regional lines in the Commonwealth. So I'll stop there and let Celeste do her magic about what happens at Frontier.
Hi, good afternoon, everybody. Hello from Tennessee. I'm down here in Johnson City, and we're located at our Turning Point facility for Frontier Health. And that is probably the first question that some of you may have if you have not participated in some of our meetings and discussions, is why would there be a call center for Virginia that's located in Tennessee? And the answer to that question is Frontier Health serves the upper 8 counties of East Tennessee, and we have locations in those 8 counties, as well as Lee, Scott, and Wise County in Southwest Virginia, the PD1 CSB. And so when the call center discussions came about and Region 3 was looking to either develop a new call center or go with one that was existing in an effort to kind of, I guess, give the state some more options. So they elected to go with us because we have been doing the Lifeline, National Suicide Prevention Lifeline calls for many, many, many years for Tennessee. And so we already had a great deal of experience with that with our call center. And so we have adapted to the Virginia model of crisis care and behavioral health. And that's been quite an adjustment for our team. But we are very glad to be on board with you all and be on board with Laura and her team. She kind of explained some of the routing by area code. And so we do take calls from Region 3 as primary. And then the goal with the department and with the state is that all calls be answered in state. And so if Frontier Health is not able to get to a call, it rolls to PRS. And if PRS is not able to get to a call, it will roll to Frontier. So we back each other up. So there's a consistency across some of the regions, and that helps us to have some communication with other parts of the state and other programs, and be able to participate in the big picture as well. So next slide, please. So we have through Frontier Health, and some of you may have met these folks on other meetings. Sandy Odell is our PD1 executive director, and she and Christy Hemans kind of head up the show here for Frontier Health. And then of course we have Sherry, who's our senior vice president. And then we have Tiffany Hall, who has been on board just for a couple of months as our call center coordinator. And I know that lots of you have met Julie. She's our call center liaison, and they're both on the call today. So say howdy to them. Next slide, please. So at Turning Point, we operate within the Tennessee crisis model. And so we have on site here in our building, our call center, our mobile crisis team, which in Tennessee functions as mobile crisis and emergency services combined. So just a little bit differently from the Virginia program. We have a 24/7 walk-in center that we take clients in any type of crisis perceived. Like Laura mentioned, it could be housing or any kind of needed support. So those are similar to the CTAC programs in Virginia. We have respite and 23-hour observation, as well as our crisis stabilization unit, our detox unit, and our 28-day residential programs here on site. So we are a busy place and turning point. Next slide, please. So we take the calls from 988. We have our Virginia Regional Crisis Line. We have our Frontier Health Tennessee Crisis Response Line, the Tennessee Statewide Crisis Line, and then of course the Veterans Rollover calls that often come through 988. We have done dispatch for the PD1 ES team for many, many years. As I stated, they're a part of our Frontier Health Continuum. So those are our active Frontier Health clients. And so we are pretty familiar with the way things work on the Virginia side. We are learning very quickly the process for the mobile crisis dispatch, and our hub operates out of the New River Valley CSP. And then we also dispatch our mobile clinicians here in Tennessee. So we do de-escalation, interventions, one-on-one discussions, and then, you know, any kind of referral, whether that be to community services, same-day access, care coordination, mobile dispatch. Right now, one of the key points for, I think, every call center, at least mine and Laura's, we are in the data entry conundrum. And so we are both, I think Laura still is having to do dual documentation. So that is one piece that is a call center perspective. So hoping that we can all come to a quick resolution for that. But as part of behavioral health, we coordinate calls between hospitals, schools, jails, any kind of community stakeholder, individuals in their homes, medical offices, and we link those clients with whatever service is appropriate for their level of distress at the time of the call. And of course, with 988, the goal being to divert calls from 911 centers and handle those behavioral health calls in the behavioral health network. And those of you who have worked with our call center navigators and liaisons know what a incredible job they're doing helping us map out all of these services and programs and linking all of us together. So thank you all for that effort. Next slide, Alexandria, please. So at Frontier, we are much, much smaller than Laura's crew. We have got 25 full-time and PRN staff. We are on site 24/7 here at Turning Point. We have a shift lead on each front end of the week, back end of the week, day shift, night shift. We have 24-hour clinical supervision. We also have our mobile clinicians here in the building on site 24 hours a day. So if there is something in addition, you know, that needs to be handled in that moment, then our clinicians step in. Our call center staff, though, the paraprofessional, as Laura mentioned, we are a large number of CPRS certified individuals and peer level of experience. We feel like that really adds a lot to the call center service, that they can identify and relate with callers in ways that sometimes folks who are non-peers have difficulty with. And we have about a 4-week training period, somewhere between 150, 160 hours, give or take a little bit. Next slide, please. So we have had some changes in our phone system, and so our data is in bits and pieces. But from February of last year, we began taking calls from Virginia in December of 2021. It was like December 27th or 28th, just right at the very end of the year. So this data goes back 12 months. So from February to February, we received just over 15,000 Lifeline and or 988 calls. And those are about an equal split between Virginia and Tennessee. We were very curious to see what those numbers would look like. And it is almost 45 to 55% split. The answer rates are very comparable and the number of incoming calls are very comparable. We did get with Vibrant Health and managed to get our incoming lines split between Tennessee and Virginia last month. So all our data moving forward will be Virginia data. So we were super excited about that. But we did have on our regional crisis line about 4,500 calls come in over the last year. And then we also take rollover calls from Highlands Community Services in kind of lieu of their answering service. And so around 500 for those. And we have 44 calls documented on our PSAP line. I'm not 100% convinced that those are all actual PSAP transfers. When we open up new lines, sometimes we get those wrong numbers, hang up calls, and things kind of get inadvertently transferred in. So, but out of our Virginia calls, that's a relatively low number for the last year. So you can I went ahead and included that. Actually, probably the first of those calls had maybe come in, late last summer. We developed our PSAP line in August. So that's kind of a better time frame if you want to think about from August through February. Next slide, please. With 988, in July, we saw a huge increase in call volume the first couple of weeks, but those calls were not, most of them were people asking if 988 is a real thing. Does this actually work? Some hangups and wrong numbers. The actual number of callers that were requesting help and that we provided a resolution to stayed pretty consistent with the pre-988 volume. It was not until August and into September that we saw the huge jump in callers that were actually seeking help. Next slide, please. So we have broken down our call data into regions, and this is an average based on the Vibrant report that we get each month. And so you can see the vast majority of our calls are coming from Region 3. So very, very few calls coming from other parts of the state, and averaging about 800 calls a month from our region. Next slide, please. So this is just the flow for the Marcus Alert phone calls, whether it comes in through 988 and, we talk about the caller's need, and then, we triage it with the Marcus Alert level, and depending on what those levels are, make a decision about what's going to be the best process. On the flip side, when it comes in through 911, they also triage it based on the Marcus Alert level and the incident type with their CAD system, and then determine what's going to be the best course of action. So whether it originates with 988 or whether it originates with 911, the process is very similar. Next slide, please. The dispositions that we have for our Lifeline calls is de-escalation, community referrals, mobile crisis dispatches, coordination of care, same-day access referrals. Very few end up being referred to emergency departments. And then, of course, we have the active rescues or the suicide attempt in progress, which would be the level 4s. Those are about, I want to say maybe 1.3% of our total calls. It's a very, very low number that we have to activate the active rescue on. By far, the vast majority are the de-escalation calls or the transfers out to one of the mental health CSBs for services. Next slide, please. So we have had several meetings throughout our region to talk about the Marcus Alert system and planning. With PD1, Chris Parks has been a huge help to us here at Frontier in learning the Marcus Alert process and learning the systems, the law enforcement and PSAP systems in Virginia. And so we are on a very positive track with our meetings so far. And I feel like have a very good communication system set up. And Julie participates in tons and tons of meetings and getting to know folks involved in the PSAPs and helping to plan for the Marcus Alert rollouts. Next slide, please. So one of the some of the key points that she has brought up from some of her meetings, and some of you may have questions about some of these, is that one of the concerns, a big concern, of course, is how the length of time for transfer. Right now, our average speed of answer is right around 6 seconds. PSAP lines have the highest priority coming into our call center, and we do have a dedicated line for the PSAP transfers. From July through December, we only had one call that was transferred to us from a PSAP that we had to in turn kind of roll back into 911 and activate law enforcement intervention. We are learning, like I said, the Virginia systems. So knowing the difference in the PSAPs and the DBHDS maps and regions and counties has been extremely beneficial for us here in Tennessee. Some questions about processes for third-party callers, and the big piece of the whole discussion is that we are all in this together and developing tools and services for clients in need. And I think that's the really awesome thing about this process. Next slide, please. So we are all in the communication business, whether it be phone, text, chat. Frontier Health is beginning to explore the text and chat process. We do not currently have that service, but that is in our plan within the next year to get that developed for Region 3. And of course, the priority is the safety of our clients, and we just look forward to continuing to work with you all and get to know everyone and be your call center. Thank you all.
Thank you so much, Celeste, and thank you, Laura, as well. It looks like there were maybe some questions in the chat, but it looks like Laura might have answered Heather's question that she posed in the chat. Yes. Were there any other questions? We have a few minutes before we go into our next presentation from Culpeper Co-Response. Any other questions on 988 or for either of our call center vendors in the state? And you can always put any questions in the chat, or you can raise your hand, or you can come off mute if no one else is talking.
Hey, Celeste, how you doing? This is Nelson Smith, Commissioner DBHDS. How you doing?
I'm great. How are you?
Good, thank you. Thanks for the data. I got like a million questions, so tell Christy I'll be looking for a meeting here shortly.
Okay, absolutely.
Thank you.
All right, thank you, Commissioner Smith, for joining our meeting today too. All right, so we can go ahead and move into our next presentation, excuse me. And this is from our co-response team in Culpeper. So today we have with us Chief Chris Settle, and I've recently learned Chief Settle was acting in that role, and he is now the permanent chief of Culpeper. So congratulations, Chief.
2 weeks
We
old.
also have Lieutenant Brittany Jenkins, also with Culpeper Police Department. And then from Rapidan Community Services, we have Ms. Ryan Banks and also April Cook, who are both joining us from their Behavioral Health Division at RRCS. So without further ado, I'll go ahead and pass this off to you all. Actually, I would actually like, I'm sorry, to say something else. So recently, we were allowed to do a site visit and actually do some ride-alongs with the co-response team. And that's kind of what led to us asking for this presentation. Not only did Culpeper PD kind of open their arms to us and let us into their police department and really get to meet with a lot of officers, but we were able to learn so much from all of those co-responders. So from the officers and also from the mental health professionals from Rapidan about just the passion that they have for their community and what really drives them to continue kind of pushing through, doing this work, being innovative, where co-response is not standardized at this point in the state of Virginia. So they're pioneering a program and seeing how it can work in their community and making changes and adjustments as they go along. So I'm really excited to hear this presentation. And now I will pass it off to you all.
Ryan, you want to go first?
Sure. As Alexandria said, I'm Ryan Banks. I'm the Senior Director of Behavioral Health. And Alexandria, could I get next slide also, please? And we are excited to share with you our program. We are very proud of the program that we have. And we really just wanted to try to give you some framework around what we're doing, what we've learned, and hopefully answer any questions that people may have about what we're doing and what we've learned. And we will provide some data and some other things like that along the way. We are, Chief Settle and I are going to give a little bit of history around how we started this program. I think he and I are the only ones left from when the initial conversation started, which actually predated the Marcus Alert conversation. As a community, we recognized that we needed to do something different. We wanted to do something different. And so there were a lot of conversations around what can we do. We leveraged community resources to come alongside with us to impact the community in a different way as far as funding and getting creative around that. And then the Marcus Alert pilot really jump-started our small little pilot that we had started with only, we only had 2 staff to start. And then once we were able to kind of invest in start with the Marcus Alert pilot program to expand and grow. So I will let Chief Settle jump in on the law enforcement perspective and what they were experiencing, and really our partnership where they just kind of came to us saying, what can we do?
Thanks, Ryan. So yes, I mean, it's no secret that law enforcement was seeing a tremendous increase in mental health crisis calls even before the COVID-19 pandemic. Back in 2016, 2017 is when the conversations actually started about co-response, as we have seen across the country, some other co-response programs popping up across the country. And I did some research and found that, there was a program in Rhode Island and Colorado that was having some success amongst some other states with co-response. So we kind of started having these conversations. And the big decision we had to make was, first, do we have a dance partner? Do we have a CSB coming along? We have this partnership, or some other agencies across the country, or the law enforcement agency was going about co-response all on their own, and they were hiring their own co-responders, which is another model that it does work as well. And so we had to decide that. So we looked at those different models of having our own co-responders in our building working independently, or having those co-responders who work under CSB but are embedded with the Colorado Police Department and kind of work for us. And that's basically what we went with. We developed a partnership with Rappahannock Community Services Board, and we made it through, and we're still making it through. It's a work in progress, but we have seen some success. And at the end of the day, it's pretty much what it says on our PowerPoint: is how do we serve our citizens better, and how do we serve those clients and get them services as quickly as we can. So we're offering services to them on the street side, curbside, instead of that time period with putting them in a police car, criminalizing mental health, putting handcuffs on them, taking them to a CIT center where we're offering services right there on the street without that stigma and without that criminalization of mental health. So, did I cover it, Ryan?
I think
I will tell you as this, and I'll have a caveat to that, is since then there's a National Co-Response Alliance that has now formed, which is addressing specifically co-response, and they provide a lot of good resources and training. So we've kind of partnered with them and kind of seeking their input. They're kind of like the forefathers of co-response, and we've been kind of leaning on them as well.
Yeah, I think that covers the history. I think our existing relationship helped a lot in CIT and just in community partnerships, being able to make that decision. And I guess we can go to the next slide. So I will start on my end. We are the employer of the co-responders, as Chief Settle said, and we have our employees sitting at and existing within the police department as their area of employment. And so we have funding through a local foundation. We have funding through the Marcus Alert pilot. And that is how we are funding those positions. And those positions are fully funded through those funds. We do not attempt to try to collect enough information, as Chief Settle said, curbside, to be able to process medical billing. That is just not a realistic expectation of a crisis situation that required co-response. It required law enforcement and mental health. So you can imagine, I'm not as familiar with the levels, but your levels, so you've got your different levels of response. This was not a response that wouldn't include law enforcement. And as a caveat, we do not have a fully staffed mobile crisis. And so we do also probably have co-response responding maybe a little more often than if we did have a fully staffed mobile crisis unit in our area. So I know that there are typically a lot of questions around how a program like this will be funded. And I think it's important to look for creative funding because I don't think depending on billing is a realistic expectation for a service like this.
I think we're next slide. Yeah. So, April.
Yep. All right. Hey, everybody. Okay. So this is where I jump in. And so I'll just briefly give you guys some background. I am the clinical supervisor for the program. So I'm just going to go over some of the kind of nuts and bolts So fortunately in Culpeper, we've been able to have 2 full-time co-responders, which has helped significantly. Their hours are from 9 to 5 and from 3 to 11. That helps us cover any roll calls, so that we can kind of make sure that we're having good communication and discussing any cases and any needs. Excuse me. And as far as the duties of the co-responders, the PD secures the scene and make sure that the scenes are secure for our co-responders, and then we come in and respond to any mental health crises, any of those types of situations that can involve safety planning, that can involve referrals, encouraging people if we feel like it's critical and necessary to get some voluntary evaluations. And then, of course, we coordinate with our CSB crisis service team and other CSB services to make sure that the individual or individuals get the critical services that they may need. And I am ready for the next slide. Okay, and so I think that this one.
Yeah, just to stay what April said too is a real big thing for us is mitigating those people in crisis when they're the worst moment in crisis. We have seen some data that shows that those are cases where we're preventing them, or they don't really have to go into an emergency room, which takes up more resources, or into a CTAC, what takes up more resources. We're seeing where our co-responders are mitigating those crises at the scene, which for any community, that's what you want to see is mitigation and using less resources and less emergency rooms to fill that. So developing the program, what we kind of consider, and I'll be remiss if I didn't talk about Chief Jenkins, who was my predecessor, who was really the driver on this. And our main concern was embedding a mental health professional into a police department. As we all know, that is 2 totally separate, different cultures. The 2 agencies have separate missions, and putting a co-responder, a mental health professional into a police car, or into a roll call room, or into a briefing room was challenging, and that was our primary concern. So luckily, we found our first co-responder that was embedded with the police department. His personality really melded and meshed with our law enforcement officers, where they actually start referring to him as a noun, as a tool. His name is John Bankus. They actually refer to him as the Bankus, and I get the Bankus actually is a tool, which I thought was great.
Like 20 minutes, I'll show you how to do it in the office.
Which I thought was great aspect of that. And so then we kind of looked at, once we kind of got the culture and the police department really kind of accepted him, our police officers really accepted him, what model worked best. And there's some co-response models that the co-responders truly embedded with the police officers every day, which means they're assigned to a police officer. They go out and ride in the cars. They respond to other types of calls of service that really doesn't pertain to mental health crisis. But they're there for those mental health calls, and we kind of direct those officers that have the co-responder to those mental health calls through our PSAP, and that's the model we adopted. There's other co-response models. It's kind of a respond model, where a co-responder just sits in the office and responds when the agency needs them to respond to a crisis. So we thought it was, every community is different. So you got to look at your own communities, your own makeups of your agencies, your own makeup of your CSB to see what they're comfortable with, to see what right fit is for their right community. So we kind of went mostly the embedded route, and that co-responders assigned to an officer for that shift. And sometimes that can be multiple officers. And then they're assigned and they're in that car. So we outfitted them with a uniform. We outfitted them with a ballistic bullet resistant vest. created some internal policies and practices for those co-responders when they're on patrol, and office space. So we were going to put them in office space kind of away from everybody and actually next to the chief's office to make sure they had a nice quiet space to work. But we realized that was probably be more detrimental for us culture within the building to keep them away from everybody. So we actually put them right slap dab in the middle of our patrol section, so our guys interact with them most. And we brought the second co-responder on, and she, again, her personality, her police officer personality kind of melded. And hopefully that was kind of a reason we put them in the middle of our patrol section. It's for that camaraderie, rapport, and that trust that between the mental health clinician and the officer that had to be established. We're in the process now of creating a co-response academy, which is, we kind of got that from the National Co-Response Alliance. That's kind of one of the things they recommend. It's kind of a training academy for co-responders to deal with kind of officer safety issues for the co-responders. If an officer's in trouble, what should the co-responder do within the police car, out of the police car, cover, concealment, all those basic needs that a person should know when they're out riding in a police car. So we're actually doing that, I believe April scheduling that for next month. So that's going to be a 2-day training for all of our co-responders in the Rappahannock Community Services District. And hopefully we'll kind of, any new co-response that comes on, we'll get that academy training. And we hopefully do that as an annual refresher for all our co-responders to have that type of training to ensure not only the co-responders' safety, but their officers there with safety and the citizens' safety. So I'll be remiss also not to introduce Lieutenant Brittany Jenkins, who is also on this call, who kind of handles our day-to-day operations for the co-responders. And I know I'm missing some things. So Brittany, I don't know if you have anything to add to that.
I do, if you guys don't mind. When we talk about integrating mental health workers into police department culture, we have to understand that police departments, law enforcement as a whole, has a very unique culture. We're very exclusive, right? So I think it's critical when doing the hiring process to find the right person that's willing to do all of these things we're asking of them, because really they are the boots on the ground with us out in the streets, interacting with people in their environments, right? This isn't a clinical setting, a sterile setting where it's safe and secured for the most part. There's a lot that goes into that. So I think that it's really critical to note that our past chief and current chief worked very hard at making sure that there was buy-in from our culture, as a whole, from the top down. They said that this is what we were going to do. It's very important, and this is why it's important. The location of the office space was critical. It was absolutely instrumental in having our officers walk by them day to day and say hello and get to know them as people and, case talk with them. A lot of times we have these constant interactions with the public. A lot of mental health consumers that we deal with on a day-to-day basis. So having the ability to kind of game plan together was a different process for us. Usually we respond to a call, we handle the call when we leave. So it was really important for that. It was also really important to get them doing ride-alongs, whether, John, when he first came on board, he just rode along. He was still working through his training through CSB and the process that he had to go through there, but he was riding along, just getting to know our officers, attending the roll calls and becoming familiar with our processes. So I think that those are really key things to point out, that it takes work from an agency to support these guys, because they have no idea what they're about to cross into.
We're ready for next slide. There you go. Now that Brittany continue, I think Brittany probably could hit on most of these. Go ahead, April.
No, it's Ryan. I was just going to say, it was a very specific recruitment process that we did for this program for a couple of reasons. One, obviously, it's a non-traditional setting. It's a community-based setting. It's also a new program. And so you need someone who is has the ability to understand that it's a new program and that things are going to change and that their feedback and input is going to be part of what develops the program. But also a bigger piece that we were looking for is we weren't sure, because no one went to school to do co-response because it didn't exist, right? So we really weren't sure what type of professionals were going to be out there to embark on this journey with us. And so we were very careful and very selective on who we hired to put into the program. And it really has to be a desire. There has to be a level of passion behind the work and understanding, not the specifics of the work, because there's really no way to understand that, but just understanding the goal of it and the difference that it is behind some other mental health work that they might choose to do.
And I'll just add, working through the operational challenges, I know Brittany kind of hit on most of these things on her slide. And you know, it hasn't been all rosy all the time. It's been a lot of communication between CSB and the police department on some operational challenges, because we're all working within a different environment. We're working within the CSB environment, and CSB is working within in a police environment, and it's, you know, it's two different animals, and trying to meld those together has been some challenges. So it's really important that CSB and the law enforcement agency really has a pretty great working relationship, where I can call Ryan on a cell phone, or call the director on a cell phone, or Brittany can call April on cell phones and hash out these operational challenges and getting those together. Because again, it was a new program. We had no clue what we were doing at the beginning, and we just kind of put it up and let it go, and we've seen some tremendous success. So Brittany, anything else on this slide?
No, I would just say that I think the conversations that we have on a regular basis are instrumental. And I think it's important for everybody to realize that, you know, with what Chief said in regards to being in different environments, you know, as far as CSB and law enforcement, both of us have different challenges we're facing individually. So law enforcement on a day-to-day basis is answering these calls. And, you know, when we're trying to mitigate, as you know, with our co-response, we're dealing with CSB rules and regulations, Department of Human Services rules and regulations. We're different policies that everybody has. And so I think it's really important to recognize that without those open lines of communication on both sides, it would be a mess.
Okay, next, there you go.
All right, I think this one is mine. All right, so essentially some of the stuff that I have been tracking, and this is utilizing a bunch of different data resources. So this would be our EHR records. This would be, you know, working with different agencies to get their data. So I'm pretty much like kind of collecting a bunch of stuff from a bunch of different areas, but some of the big things that I've been trying to track and keep focus on are some of the referrals to see, you know, how often are we referring? Our referral could be to a CSB agency, a referral could be to housing, a referral could be to, you know, a local, you know, a local outpatient clinic. So it really kind of just depends on that client, particular client's need, and really focusing on where we can meet them. And so this is the data that I've been tracking over the past year. And then we, of course, will continue to track that. And so we can, so next slide. So voluntary evaluations are what I'm looking at. And again, this is specifically from our kind of our credible notes and a couple of other EHR record stuff and information I'm receiving from co-responders. So at this point, I just, over the past couple of months, realized we probably need to be tracking this and be tracking it regularly. So this is a new tracking process for us. It's a learning and growing curve about what we want to track and how we want to track it. And it's consistently a conversation. Data collection is consistently a conversation we're always having. And so voluntary is essentially working with somebody to get them, instead of necessarily, hopefully we're not going to have to ECO you if you're capable of making that decision, and just encouraging people to get an evaluation in a less how am I going to word this, a less intense process, I think is the best word I can find right now. So, and this is also as we're working with hospitals and different agencies, one of my goals is to be able to kind of track safety planning and keeping somebody at the house versus sending voluntary somebody through a voluntary evaluation process, just so that, you know, we can continue to work together well. So that's the data I have at this point for our voluntaries, and I am ready for the next slide. The ECO criteria and the ECOs in 2022 are based off of what based on data for the co-responders physically being at the ECO. This isn't necessarily like following up on a referral. And we are again tracking that data and that data usage, just so we can see what months or, you know, if there's trends that we're seeing and if things are going down. And I am ready for the next slide.
Yeah, and just to touch on the data as well, and I think April touched on a little bit. Data, of course, we all know the animal of data, and you know, a lot of data the CSB has is part of the mental health record, which law enforcement doesn't have. So I think data is always going to be a challenge for law enforcement and CSB. And we collect our own data, and CSB collects their data, and what we value in data is different with CSB values data. So, and Brittany can touch on this a little bit more, as our co-responders do so much more than divert, you know, ECOs or do or promote voluntary evaluations, and tracking that to put the true value on the co-responders is a challenge. And we try to capture it in-house because we know there's going to be calls for funding in the future. We know that these foundations and these you know, these public-private partnerships, you know, may expire, and we know that this data is going to be important to go to our city councils, our board of supervisors, our legislation to get this funding. So and I know Brittany has a lot of strong comments on this as well. So she's in charge of our peer support team, and she has a different look at this as well.
Well, and I think that's important to note too. The peer support side of things for me is what helped me understand co-response a lot better, because it was eye-opening to me to realize like how much you can do at a peer level. And I think that both programs kind of mirror one another. I think that it's important to realize that peer support, we become subject matter experts on resources, you know? And I think that that should be the same for co-response as well. Understanding front, back, side to side on what resources our community has available to our consumers, because a lot of times there's a lot of people falling through the cracks. You know, there's gaps in the system, and we all know that, and we recognize that, you know, there's gaps in law enforcement and there's gaps in mental health. And so I think it's important to note that our co-responders riding along with us day to day get to see those. And I think that they can't sit idle like we can't sit idle. It's hard for law enforcement officers to see a problem and not be reactive. You know, we're fixers. You know, it's really hard for law enforcement to see a problem and be told there's no solution to that. And our co-responders have kind of fed into that as well, just being immersed into this culture. They do not sit idle very well. So what we've noticed is, you know, most of our law enforcement calls have some type of mental health nexus, you know, a linkage to mental health, whether it's domestics, having a family history of abuse that's going on there, substance abuse, elder abuse, you know, which really CSB kind of touches a lot of those, the most of those things, intellectual disabilities, you know, and we respond to all those things because the elephant is in the room is, you know, we're a 24/7 operation. So when CSB and Department of Human Services close up shop for the night, we're still getting the crisis coming to us, you know, whether we're trained or not, it's coming to us. And so our co-responders have taken a team approach to this where we can best serve our community by getting resources to the public immediately. You know, I know we talked earlier about it not being billable. Well, that's really a benefit to the public because a lot of people can't afford mental health services. A lot of people don't have insurance, don't have, you know, the way to access those things. So our co-responders should be the subject matter experts on our nonprofits, on all of the other resources that we have at our disposal that we can say, well, if we don't do something like this, well, then I know who to point you to, you know. So they do a lot of the follow-ups with these people. When we interact with a public on a call for service, for example, say it's a parent having a problem with their juvenile. My kid won't get, you know, doesn't want to go to school. How many of us have dealt with the child who it's a juvenile matter and, you know, law enforcement's called to that, but really there's a root issue to that doesn't necessarily need law enforcement. Maybe there's some family dynamics, you know, that are problematic that CSB and our co-responders can help work through. They're responding to all of these different types of things. They respond to our investigations unit, where we have victims of violent crimes. We ask that they follow up and provide resources to them as well. So I know I'm going to miss certain things that they do, but it is so much broader than what we could put on a bullet point. That we utilize them for everything, and it should be a team response from both of us. They need us as much as we need them.
And just to touch, and I know Lieutenant Jenkins is just as passionate as me about co-response and providing services to our citizens. And I'll do this, and then I've seen so many examples of this. If you know, law enforcement, as we know, we're not trained in mental health. We're not mental health evaluators, and everybody hears that. You know, some sheriffs across the state and chiefs saying we're not no longer responding to mental health calls. You know, let the CSB come out, and we're not like that. We'll never be like that. However, having that co-responder or that behavioral health specialist on the scene, relieving, once the scene's secure, relieving an officer and taking over that call and mitigating that crisis and taking that burden, that stress off of that police officer is truly the benefit that we have seen. And it provides such indirect benefits to us as well, as far as recruitment and retention. I mean, we all know in law enforcement, it's so difficult to hire and keep police officers, but because a lot of police officers leave agencies because they're sitting in the hospital for 14 hours or 30 hours. They are responding to all these mental health calls, and that's not what they signed up for. They signed up to be police officers. They signed up to be fighting crime, you know, like kicking butt, taking names type of thing. And they're handling mental health calls. And it is such a relief for that officer to have a mental health clinician or a behavioral health specialist to take over that call. And it's been a recruitment retention tool for us, to be honest. And it's just a kind of indirect benefit we see. So I'll let April speak about.
Well, and just before April, I'm sorry, let me just add a story that I just recently, sorry, Ryan, sorry, April. So this last weekend that we worked, I just want to share this because this really talks to what we're talking about right now. We had a child suffering from ODD, oppositional defiance disorder, among many other things, different, you know, isms, disorders, you know, all of these different clinical things that he was suffering from. When law enforcement got there, parents were kind of at their wits' end. They were like, we're about to take the child to get an evaluation at the hospital because medications aren't working, so on and so forth. And he had just changed medication. So at this point, he hadn't had an opportunity to really kind of get used to it and have it, you know, take its proper effects. So it was probably about 10:45 at night, and he was destroying this house, throwing things around and being very destructive. We got him all outside of the house and calmly talking, but he was very taken aback by law enforcement being there. He didn't want to talk to us. He didn't want to respond to us. His head was down. His eyes were down at the ground. I think he felt like he was in some kind of law enforcement trouble, which is not what we want. I called Tracy. I said, Tracy, who is our co-responder, I said, Tracy, I've got one for you. I think he's perfect for you. I think you could follow up with him and his family and provide resources and support for them because they're exhausted. So she shows up, and anybody who knows Tracy would know that she just comes bouncing in there. She's got a really positive, happy personality. She's very approachable, and she goes up, and I had already briefed her on the situation, and she went directly to the little boy and started, you know, fist bumping him and talking to him in his own lingo. And he just lit up, and they went around the corner and had a discussion about what was going on and, you know, why that was escalating, kind of figuring out his triggers and some of the stuff that was going on. And then after they were done having a conversation, she met with the family and said, you know, can we provide resources to you guys? Because so often, how often do we forget that the families that are dealing with those in crisis are in crisis themselves, you know, for varying different reasons. So providing resources and referrals to them as well. So it was just a really successful conversation that took place. I was really proud of our co-responders. I'm proud to see the direction that we're going with this kind of stuff. And it was a good example of kind of what they're doing. I'll shut up now.
No, always good. And I'm always fascinated that we're learning each other's languages. Cracks me up. Like you threw out the ODD. I threw out Bolo the other day. I was like, okay. So like, we're all learning each other's language. Okay. Yeah. So, you know, speaking of like providing referrals and connecting families, I mean, I would say, you know, just some of our success stories, and this is multiple families, I can say where we've been able to, especially ones that are high conflict families, where we've been able to link them to family supports. We've been able to encourage them to work with the school and the school social worker and like therapeutic day treatment and intensive and home services and case management stuff they might not necessarily know exists, right? And we have a lot of families that may be in that middle ground, right? Not quite enough to be able to have, you know, some of the lower cost insurance options, but you know, they can't exactly afford the most expensive insurance either. And so they're in that middle ground where they, you know, they might need FAPT funding or additional funding sources, and we can kind of educate and support them. And we've done that a couple of times. And of course, connecting them to our RCS case management services when appropriate. So again, the benefit of having a CSB connection is, you know, we can, you know, look at those services that we offer through the CSB, and then we can also look at through those, you know, school resources and other community referrals. And we do like we do a weekly case consultation group so that we can discuss those cases. Again, we've been able to connect several families and individuals to our C Center, which is also another low barrier option. And again, those low barriers are our winner to get people into services. Where we've had individuals that need some, you know, access to natural supports, they're having difficulty maybe accessing stable housing, and obviously when you have those challenges, it can be difficult to, you know, keep connecting yourself and keep compliance with mental health services, because you got to be able to get there. And we were able to connect people to like family members so that they could start getting those rides to the C Center, getting those rides to the outpatient therapist. and really encouraging that, getting them connected to peers who will walk them through that. And then the other one is we've had several individuals that have needed either an evaluation at our crisis center or have been under the ECO process, and we've been able to help be the do that language piece, right? Like, you know, say, hey, we have somebody with an SSI where, you know, the law enforcement partner might be like, what are you guys talking about? Where we can, you know, directly contact our crisis services agency and say, hey, we have, you know, somebody that, you know, isn't able to follow a safety plan. And we've had that with a couple. I'm thinking of one young man in particular who was making homicidal statements and had an actual plan to harm family members, and we were able to get them out of the home, have a very direct clinical conversation, and do that gap with and facilitate with law enforcement. How we can best support that and keep everybody safe, right? And ask those questions like, you know, are there weapons and those types of things. So, you know, we've been very fortunate to be able to have those conversations. We've been very fortunate to in our monthly meetings and our weekly case consultation meetings to be able to like support each other. And discuss any concerns. And so it's been a really good partnership in that area. And again, we look forward to, because we all care about this, serving the community and, you know, really just helping everybody at this point. So that is what I have for the success stories. And
April, can I share a success story real quick?
Absolutely.
I know we got some time, but when we first started this program, John, who was our first co-responder here embedded with the police department, he was still in training. He really wasn't supposed to be out providing any type of counseling or any type of services yet. He was just kind of a typical ride along, just observing, making sure this is what he likes, making sure this is what he signed up for, and make sure this is what we signed up for. So he was trained. So we were on a call one day. We had a call for a barricaded subject, a Vietnam War veteran who was in crisis. We didn't know why he was in crisis, but said if law enforcement showed up, he was going to start shooting his AR-15 out of his trailer. So we respond, we set up a barricade, we set up a perimeter, you know, law enforcement textbook stuff. And we had a sergeant that was working that day, and Brittany knows who I'm talking about, but he's probably been in law enforcement probably for 35 years, stuck in his ways. True non-believer of co-response from the beginning, like, why are we putting this guy in their car? This is a safety risk for all of us. I don't understand what we're doing. So he is riding with his squad that day, and we have this situation. And one of our officers decided, well, let's call him. You know, let's call this guy in his trailer and let's get John on the phone with him. And we probably wasn't supposed to put John on the phone with them, but we were going to try it. And Ryan knows the story too. And John starts talking to this guy and totally de-escalates the entire situation. I mean, this is a situation we knew we were going to have to breach the trailer, probably use some type of force, probably would have ended very badly for this citizen and or for a police officer, a very serious situation. And John was able to get on the cell phone and talk to this guy as a behavioral health specialist, not as a police officer, and got him to come out with his hands up, and we take him into custody, and John begins to talk to him to the point where we actually take the handcuffs off of him and talking like two human beings, John and this Vietnam War veteran. And they sat and talked. And at the end of the day, you know, again, we didn't have to breach, we didn't have to use force. The outcome was peaceful. No one got hurt. And John, this guy's in this yard talking like two buddies from way back, and actually got him to do a voluntary evaluation and provide some help. And at the end of the day, his crisis was his utility building got cut off. And that's all he was upset about. And it created a trigger for him. And so at the end of the day, this sergeant, who was commander of this whole scene, and he was stressed out because he knew, you know, something was going to end bad. He was going to be on, you know, the one calling the shots. doing all the paperwork at the end of the day. And it ended peacefully. And so he sends me an email, and this sergeant, he hates a computer too. And he doesn't send lengthy emails. He sent probably a 3-page email to me, how wonderful this co-response program was going to be, how we needed more. And he said if he needed any roll call talks or he needed to talk to any officers who were non-believers, he would be the one to do it, to talk to these officers and say, we need these people in our office. And he did. And now he's like best friends with John. They're actually like really close friends. And I can't tell you. So I forwarded the email. I redacted some information. I forwarded the email to Director Jim McGrath or Representative CSP, and he called me, and like we were like having a party on the phone. It was a Friday night, and we're like, "Are you kidding me? Oh my God!" And it was like the true first success story, and we were excited. And at that point, when that sergeant sent me that email, and I sent that to John, we kind of knew we had something really good going here, and we knew that this was a pretty good darn model. So it saved us a use of force, and it saved us a lot of liability, and it got this Vietnam War veteran to services quickly and got him de-escalated. And probably the best success story I can probably tell.
You know, Chris, it's interesting listening to your success story, because I had one that I wanted to share as well, but it's going to be very interesting on it's exactly what we've been talking about the whole time. Is the different perspective. It's the different things that are important to us. Because the one I remember you calling me about and telling me about is the one that John got down on his knees and was talking to the kid, and you were just so impressed by that. In my head, I was like, well, yeah, of course he did. But also the reason why he was able to do that is because he knew that he was in a safe environment, because he had his law enforcement partners with him, so that he didn't have to worry about the safety of the situation, and he could engage and, you know, bring himself to a more vulnerable situations. And that's the one that I remember that was pretty early. I mean, we've had plenty, we've had a lot, but I think those first ones definitely kind of stick with you and resonate a little bit more, because it definitely let us know it's going to be hard. It's going to be hard work, but it's going to be worth it. And I think we all can agree that we all want the same outcome. So we're willing to kind of do the work to get to where we need to be. But that's the story that I remember. And we do have probably, I don't know, countless other success stories. And some of them are small, you know, the frequent callers, those are success stories that engaged in services for the first time ever, right? That we've known about, or some that we didn't know about, and only law enforcement knew about. That's the other thing that's been helpful is it gave us as a behavioral health provider access to people in our community that were not engaging with us. And so we had no window to try and get them the support and help that would help them in the community. And so the co-response just gives you another window and another door to help. And I think that, like I said, it's hard work, but those stories are the ones that I think keep us going, keep us battling, keep us fighting for what we know works. And I use those words on purpose because, as Chief Settle said, it, there have been some challenging conversations, but they're needed conversations to make sure that we're doing it right, to make sure that we're impacting the way that we want, and that we're keeping everybody safe along the way. So I don't know if anybody else had any other success stories, but I wonder if anybody might have questions for us as well.
Yeah, I just wanted to take a minute and just thank you to Chief Settle, Lieutenant Jenkins, to Ryan and April for not only presenting, but, you know, allowing Alexandria and I also to spend 2 days with you all, because we learned quite a bit, and we just appreciate you coming and presenting kind of like just a snippet of what you do in your area. So we truly appreciate that. If you all have any questions, feel free to type it in. I did kind of want to say just a little bit, and one of the biggest impacts that my takeaways from the trip, and you had mentioned it, Lieutenant Jenkins, is that your co-response ride along is, or the co-response model that you have is that your mental health professional goes with you on all the ride alongs. in that there is a mental health component in pretty much every situation. And I think that's one of the things that really stuck with me, is that, you never know, like every situation that comes out, you get a phone call, it's just what the emergency is. But, every aspect of the phone call or for the response, there is a mental health component. And so it's so important to have the co-response team just go out and just, respond to what the call is, and not just specifically identifying, oh, this is a mental health call, you go out. So I just thought that that was just a great model, and a great way that you guys operate. I did want to ask if you guys could talk a little bit about how you integrate community policing and outreach in your co-response model.
I'll let Lieutenant Jenkins touch on that. But I'll tell you, it is important, especially any new program you implement in your community. In Culpeper, we're although growing, we're still a small, mid-sized police department, but we have a robust, very robust community policing that we strive and we pride ourselves on our community policing program, and our co-response is part of that. And it's important for the community to know who these two are, and they've become very popular. And they became, again, any new program with success and something new that someone's never heard of, it does spark a lot of interest. I mean, our town council, wants to meet them. They want to bring them to council meetings. Their neighborhood watch organizations wants to meet them. And it's important to get the marketing is a part of everything we do now. And we understand that it's important. And so we try to bring them at any event that we can, because at any day, any one of these citizens or any one of these groups may be encountering a crisis, and we know that the co-response will be right there for them. And the more we educate community and provide prevention and education, then the better off we are. So that's my 2 cents. And I'll let Brittany speak on anything else.
You basically touched on all of it. No, I think our agency in particular holds community policing to the highest, because it's kind of storing away our nuts for the winter, because we're going to run into a bad situation, and we want the public to understand what it is we're doing and have that relationship, just like we did with the CSB before co-response existed. We had that relationship prior to, and that was so critical in how we ended up moving into this program. Prevention is a key part of law enforcement, and it should be a key part of mental health. If someone can say, I know that this resource exists, well, let's not necessarily have to go the route of the hospital. Let's get it before it's getting to that crisis point and say, well, I know the PD has a co-response unit. I feel comfortable talking to these guys because I met them at such and such event. I got to go and do a meet and greet and shake hands with this person. And now I have a face to a name. And all of a sudden I could say, well, I met John at this neighborhood watch meeting, and I really like him. I trust him, and that's what it's all about, is to take that stigma away from getting help early on so that it doesn't become a crisis.
Thank you for that. I think we have a question from Steve.
Yes, well, I don't have a question, but we're talking about engagement and our mental health partners. I certainly want to take an opportunity to brag on our partners down in Danville. We've not fully implemented our co-response, but they do have a lot of the parts. We put them in place as we go, and have not I think we may be next in line or two away on the full implementation of Marcus Alert. We've got a lot of the pieces in place, but through our partnership, they come out. Our engagement model is also very robust, and they partner with us on our heart walks, heal and engage after recent trauma. They come out with us on those. Every time we have a homicide, we go to the area closest to it and give them information, provide services, try to lower the anxiety, and give as many facts as we can. And they're always beside us. Our partners with the mental health, our mental health partners with DPCS and their behavioral team, they show up in droves and have partners with every group going out. And we do those anytime we have a traumatic event, and it's been pretty impactful. And obviously, we don't keep up with the numbers of how many people get follow-up services, but it's always very well taken in an engagement piece. And then another thing we're doing for our addiction treatment groups are community opioid response and engagement. It's a core partnership, and they come out every overdose we have. We partner with one of those folks who come out, and we offer services. Within 24 hours, we're face to face with them, kind of debrief, because we want to know where the fentanyl is, where the bad stuff is out here on the street. We also want to offer services and put a different face to law enforcement, and that whole idea of treating them as victims has been bought into by that police department down here, and we have a great partnership with them. So as we build out the rest of our Marcus Alert and the rest of our co-response, which is there, they come out now, just not completely implemented. We're working on the MOU now, and they come when we need them. And of course, they come out as through the 988 calls, but and the mobile crisis is in place. But absolutely great partners, and I couldn't ask for more. So I just wanted to point out the engagement is huge for us, and they've been a great support of our engagement efforts, and that's changed our community support over the last 5 years.
Thanks for that. That's great to hear. Let's see, I see a lot of good positive feedback. I did want to ask and touch on something, Lieutenant Jenkins, if you could kind of expand on it. I know I'm picking on you, but I think it's a component that is so important, but we don't always think about it when building out co-response team. But can you talk about your self-care for your officers and your co-response?
Yeah, I think as a whole, you know, we talked about before how I was our coordinator of our peer support program. It didn't ever dawn on me how these calls for service were going to impact us until it impacts us. And that goes the same for our co-responders as well. And so I think it's important, and has been important, I guess, since our program was implemented in 2019, end of 2019, that we learn to take care of ourselves and understand that we too are susceptible to the same things everybody else is. You know, I mean, they say what, 1 in 5 deal with a mental health crisis per year, you know, that's a lot. So, you know, you take 5 people in a room, one of them's suffering from something. So law enforcement, it's even a higher number. And so our co-responders are experiencing the same things that we are. And so what we've done is we've also included our co-responders in our peer support program, and they're, you know, they have access to all those same peer support stuff that we allow our officers to have. I know that John in particular, he's a bookworm. He's a data-driven individual, and he's been so helpful for us to understand some of that stuff that's going on as far as, like, you know, why sleep's important, how to cope with certain things, making sure we're eating, doing debriefings, you know, being a part of our debrief process, and different things like that. I hope that answered some of it, but it's so much more, but that's a little bit of it.
Yeah, I'll add to that a little bit too. I have 2 very small children, and John, and I'll be talking horror stories in my office about kids and screaming and crying, not sleeping. And next day I come to work, John will have a sticky note on my desk. They see the material on your desk, and it's parenting tips for non-sleeping kids, or little sticky notes, like little encouragement notes. I get all that, and Brittany knows, everybody gets them from our co-responders, which you can't put a value on that as well. This little dad, I get a card, you know, just sitting on my desk when I came to work today from John about just thinking about you. So he knows when you have so they sense, and Tracy's the same way. They sense sometimes when we have bad days or we're struggling with things. I know it goes across the spectrum of our agency, and they do little small things just to let us know that there are people out there that's willing to listen. And I think that's, again, sad, you know, be it from all the co-response we're doing with our citizens, you really can't put a value on that as well. So the benefits are enormous.
Well, thanks again.
Hey,
all.
Chris.
Yeah.
I wanted to follow up on something that Anne said and ask your perspective about how we have our co-responders riding along on all calls, and how we came up with that decision, because it's not really the gold standard model, right? Like, because what you want is like your mental health units, right? Like where you have your dedicated
Yeah.
officers, but we melded that to address our resources and our community. So I just thought maybe talk about that real quick since she mentioned it.
Yeah, so smaller agents like us, we don't have a tremendous amount of resources. So I can't dedicate a specific officer who is specifically trained in CIT or other mental health services. We can't do that here. I know some other agencies up north from us and some other agencies across the state are bigger who do have those mental health cars, for lack of better terms. That's what they call them, law enforcement lingo, but they have that respond mental health clinician or behavioral health specialist in that CIT trained officer or some type of special trained officer, and that they just answer mental health calls, and that's kind of what they do. We can't do that. So we attempt to try our best to put them with CIT trained officers. Our ultimate goal is to have all of our officers CIT trained. We're probably about halfway there now as we currently sit. But yes, I think the model to embed them, we kind of came up with that as we got going. It's just because of that one is getting services to people when they're at their most vulnerable or they're in their worst state of crisis. All right. So when that 911 call comes in, you know, that is their worst moment in that person's crisis. And we want to make sure that we thought that getting services to them as soon as we can was important. And having somebody sitting off location maybe or sitting in the building in response would slow that down a little bit. Secondly, it's that trust, right? That trust and relationships between our police officers and our behavioral health specialists, you know, and, you know, riding like Tracy's, you know, I hear evenings, you know, riding 9, 10, 11 o'clock at night with a police officer, I hear away from their families. I mean, that camaraderie and that trust they're building, they are each other's family in that police car. And I think that bond is really important that to have between a CSB employee and a CPD employee. And yeah, and again, there's different models. I've seen it different ways. I've seen, and truthfully, air co-responders, they do have some office hours. They do have some office work. They do follow-ups. So they do have some desk time and naturally from previous cases, or like if our midnight shift, we don't have a co-responder working, their midnight shift may encounter someone at 2 or 3 o'clock in the morning, and they send an email through to John or Tracy for follow-up the next day. So part of their day is some desk work, providing that follow-up to that person that they had that call for at 2 or 3 o'clock in the morning, provide some follow-up, pointing them to services or pointing them to some self-care strategies. And we have a case management system, and really even their CID lieutenant or criminal investigations lieutenant, when it comes to case management stuff, sometimes, you know, our case manager will send cases kind of to John and Tracy if there's a mental health nexus only, or a mental health nexus and a criminal nexus, or kind of John and Tracy touch base with a detective who's handling that case as well. So yeah, it is an embedded co-responder, but they're not truly embedded for their entire shift, if that makes any sense.
Thank you so much. Thank you for giving an overview of, and as Anne said, a snippet of the work that you all do, because you are doing a lot as a co-response team, and that was really made clear to us during our visit. So I encourage everyone, if they have additional questions, you can either reach out directly to the emails that you see on the screen. And this is from the Culpeper co-response team that you heard from today. Or you can reach out to, I'll get to this slide. You can reach out to the state team, and we can always connect you with the folks that you heard from today. We're a minute over time, so I'm going to say this very quickly, but our next meeting will be in August. At that point, we will have 5 new sites that will have implemented Marcus Alert. So that's going to be Blue Ridge Behavioral Health, Chesterfield, Fairfax, Falls Church, Hampton, Newport News, and Rappahannock area, CSBs in their geographical catchment areas. So we're excited for that. Also, please be on the lookout. Soon we will have the RFP, or the request for proposals, posted for the basic and the advanced Marcus Alert trainings. And once that officially gets posted, I was hoping to see it posted this week, or actually last week, but we're a little short-staffed in our procurement office, but it is coming soon. Once that is posted, if you have any questions, I know some of you have reached out with interest in actually applying for that. I'll be sending that out also, that posting, so you can find that on the state website. Yes, so those are just some last business items I had. Please feel free to reach out to us and ask any questions that you have. And sorry, Patrick, I saw your comment about asking additional questions, so please reach out to me and we can set up a meeting with our team also. But we look forward to meeting with you guys next time, and always know that you can ask us any questions via email if you have any needs or concerns. So thank you so much. And thank you to all of our guest presenters today and educating us on what Marcus Alert is looking like across the state. So thank you.